The correlation between the clinical syndrome and the pathology in frontotemporal dementia is one of the main issues we are facing, because it's quite known, it's quite clear that the clinical expression of a disease is strictly related to the localization of pathology. But making a bridge between the clinical expression of a disease and the pathology is quite difficult, because there is an overlapping between the three different pathologies, namely TDP pathology, tau pathology, and FAS pathology, and the different clinical phenotypes. So there is a large effort in trying to match the clinical side to the pathological side. And this is probably the major effort for the future. The issue of fluid biomarkers is obviously a very important issue in trying to define the coupling between the clinical expression of a disease and eventually a biomarker that can be individualized in the CSF or in the serum. The biomarker is strictly related to the pathology. So it's difficult to combine the clinical side to the pathology, so it's equally difficult to combine the clinical aspect of a disease to the biofluid. So that is a major issue for the next few years, try to combine the clinical side to the pathology and to the appropriate biofluid, biomarkers obviously. The possible correlation between the clinical side, the pathology, the biofluid biomarkers is a game in three pieces. But it's very difficult to combine everything together, and ideally we have to come out with the right approach from the clinical side to the pathology and directly to the biomarkers, or going to the biomarker and have an idea of the pathology. Somehow we have a good example in the patient mutated for progranulin, because in that case we know the pathology. The pathology is related to TDP-43 aggregates, and we know also the biomarker, so is progranulin. We can eventually measure progranulin in the CSF or in the serum. So that is an excellent example. But the point is how to dissect the FTD people with progranulin mutation on the clinical ground. Well, a young fellow, I think, have to receive a long training to dissect frontotemporal from other dementia. Obviously, the dementia number one in terms of numbers is Alzheimer, but frontotemporal has so specific features that young fellow must receive a training in order to dissect those patients. And they have to be very supportive, because we have always to remember that FTD is strictly dependent from genetic aspects, at least in 40% of the patients. So the young fellow has to approach a double problem, the disease and eventually the genetic aspect of the disease that obviously is spreading in the family. I think that giving the diagnosis frontotemporal has several aspects, and beside the neurological aspects, the physician must be very supportive, not just for the patient, but for the caregiver and for the family. And so the caregiver is equally important in supporting, obviously, the patient, but the logical implication could be that it's not just the patient affected, but the whole family. So the neurologist must be aware that somehow this diagnosis is spreading along the family. The COVID experience has been a very new experience for humanity, and obviously related to frontotemporal is somehow raising an unusual problem. The patient is isolated at home. The pressure on the caregiver and family is probably dramatically increased, and the only way for the physician to communicate for many months with the patient was just telemedicine. So that's completely unusual, and obviously the long-term effect of COVID must be completely explored. and a follow-up of those patients is a requirement. Italy can largely contribute to science related to frontotemporal dementia. First of all, as to screen all the patients along the peninsula, because we don't have an idea how many patients we have. And secondly, it's very important to define if there is any cluster related to specific genes. The full picture of frontotemporal dementia in the peninsula can be very helpful in order to combine the situation with the genetic aspect, the biofluid, and eventually be ready for therapeutical strategies related to specific subpopulations. Well, the role of the Association for FTD in Italy is obviously very important, because when the patient receives the first diagnosis of FTD, the patient doesn't know, the caregiver doesn't know what FTD is. And to have people to start to communicate and to share this experience is so fundamental. So I think that the FTD Association in Italy has a key role in order to dissect knowledge, make people aware and more comfortable about this disease.
The general management that we provide for FTD patients and their caregiver in Brescia is usually assessed in an outpatient clinic. So in these outpatient clinics, we provide a fully neurological examination, a psychological assessment, and for selected patients, so for those who has a positive family history or young onset, also genetic counseling. For some patients, we also provide a sort of hospitalization for those who needs more assessment, clinical or specialized examination. And in Brescia also we have all the facility to assess MRI scan, FTG PET, or for some patients also to undergo to lumbar puncture for cerebrospinal full examination. Genetic analyses are available, genetic counseling and psychological support for some of them, for those who need it. In Brescia, during COVID outbreak, every outpatient clinic was stopped because we had to take care of a large number of COVID patients. We had the hospital Ospedali Civili, it became a hub for heavy patients in the Brescia province and in Lombardy. Probably Brescia Hospital was took care of the huge number of COVID patients. Some of us moved to COVID emergency unit to provide the care and emergency to COVID patients for respiratory problems or other outbreak problems. So our FTD patients stayed at home, and only emergency was guaranteed for these patients. But as soon as possible, also we started with telemedicine in order to provide support and care for every kind of therapy or suggestion. So with the COVID lockdown, we coped with the telemedicine. The hospital was stopped to any kind of clinical activity for any kind of patients apart COVID patients. We moved the hospital, moved every activity with a huge number of COVID patients. But we guarantee our support to patients and their caregivers by telemedicine. This was the first step. The second step was that we started a research program in order to identify which was the coping of patients and their caregivers with the lockdown, and we started with video or phone calls by our psychologists to these families in order to understand with the questionnaires their burden. And this was quite interesting because, of course, some of patients suffered a lot to being closed at home. Some of them could be also fined by legal problems about the lockdown because they wanted to go down, they can't stay at home, and so on. But there's also to underline that for some of the caregivers, it was a great help to have their children at home because of sharing the caregiver burden with other family members. So it was quite clear that some of the caregivers had some help for those who were not at home usually, but were constricted at home for the lockdown, and this was another way to understand that there is a great need to support patients and their caregivers in this disease. Now the outpatient clinics is open. The hospital is running again a normal activity with some new rules about distancing in order to guarantee any kind of security to the patients and their caregivers. So we already opened our activity and we guarantee an access to every kind of patients. Of course, we have lots of work to be done that was not done in the past times, and we have to move to work hardly for the next few months. At personal level, to communicate the diagnosis of FTD is very hard. It's a work that I learned during this long time of experience, and every time is like a new time. And personally, I'm telling always the truth to patients and their caregivers, also for the genetic families and genetic patients. That's the mostly hard work, but with a sort of looking forward to the possibility to find not only a diagnosis now, but a sort of therapy in the future, in the next future, or in the future that will be that has to come. And sometimes I need help for this work, and I try to have help from my colleagues or psychologists, but I hope to do my best. So after the disease, what I suggest to the patients and their caregivers is not to close in their houses, to open to the diagnosis to their other family members, and to share their pain and their burden to not only with us that are doctors and psychologists, but also to the society. So the people has to know about this disease. The knowledge about this disease has to be shared, because with the knowledge also the pain and the great effort that this disease requires during the time could be shared and could be alleviated. And the diagnosis is just the beginning of a long path that we as doctors, neurologists and psychologists would like to share with the patients and their family members in the perspective not only to tell what is the disease, but also to find a future cure definitely for this frontotemporal dementia disease.